Good evening,
Hello,
clinician. Good evening,
Good evening.
clinician,
Hello.
and welcome. Please note that this webinar will be recorded. Thank you for attending our rubber dam irrigation webinar. My name is Yolanda Botha, and I'm the Internal Sales Manager at Wright Milners. I would like to take this opportunity to introduce our speaker, who actually needs little or no introduction in this industry, Dr. Heinrich Dippenaar. Unfortunately,
Good
there
evening,
isn't enough
delegates.
time. Unfortunately, there isn't enough time to read his CV, but what I can tell you is that he is a brilliant clinician and he knows what he's talking about. Rubber dam has been around for a very long time and not just since COVID. An interesting fact is that only 20% of our audience tonight has bought rubber dam from Milners since the pandemic started. In my 25 years in the industry, I've seen many lectures and international opinion leaders presenting about this topic. But it wasn't until I actively assisted a customer that uses this product religiously that I saw the true benefit of rubber dam. I would like to encourage all of you, just like with loops or an apex locator, you need to keep on practicing and trying until it becomes part of your protocol, your daily protocol, like putting on gloves or masks. Rubber dam has always been a sensitive topic, and irrigation has always been a confused topic. We would like to invite you to post as many as possible questions relating to the topic on hand. Dr. Dippenaar will address them in the webinar. With that all said, I'm going to hand over to Dr. Dippenaar. Thank you, Dr. Dippenaar.
Thank you, Yolanda, for the kind words. Thank you for inviting me to give this lecture. It's one of those topics when you ask me, I thought, yes, is it really something that we have to still talk about? But looking at the prospectors and guys who's using it, I think it's maybe still relevant, and there's maybe a reason why people are not using it. So I decided to keep tonight very simple, very practical, and I'm going to start sharing my screen straight away so that we can down into it. I hope they can see it. Yes, Mia. Okay. Yolanda, can you hear me? Okay, sorry. Can I just get a heads up from Yolanda? Can you still hear me?
Doctor, we can hear you.
Yolanda?
Yes.
Can you hear me? All right.
Yes.
Thank you. All right.
Thank you.
All right. So thank you for inviting me, and I hope you enjoyed tonight. Those of you who have attended some of my lectures will know that I like to know how does things work. Does it work? Doesn't it work? And if it works, how should you apply it? There's enough reading for everyone on the internet. There's enough research on Instagram, Facebook, but it doesn't tell me anything. For instance, if I speak about endodontics and the file is spinning at this speed and it's has this talk, it doesn't tell me much. There's people that do the research, and if we have to still comply and say, why should I use rubber dam and all the benefits, I would just maybe share with you what benefits it in my practice. I've been using it for the last 11 years of my practice religiously. I guess the only two things I don't do under rubber dam is extractions and maybe scale and polish. Otherwise, I probably would have placed rubber dam as well. So post questions, and Yolanda will come in every now and then, and then we can stop. This is really open discussion, and I hope you enjoy it. Strangely, I was sitting on the beach on Sunday. We had a beautiful day here in Plettenberg Bay, and I bought recently this little shade tent for myself, and it was a very good investment. It's a simple technique, 4 little strings that you attach, 2 poles, it folds up in a little bag, and you can really, we spent probably 5 hours on the beach, and there we sat on the beach, quite nice, and the weather was perfect. And without this, there was no ways that I could have spent 5 hours in the sun. And I think that's the same that I think about rubber dam. You can do dentistry without it. You've probably been doing it for your whole practicing career. But it's not to say that when you're doing it, you don't realize the benefit until you actually start using it and religiously using it in your practice. Like with everything, there's a learning curve. But if you prepare it and you make life easier for yourself, it's so much more enjoyable than just sitting there out in the sun, ready to get burned. Instead of having a nice whiskey at hand, I have to share this video because I've been waiting for this shot for the last 2 years. And while sitting under the shade, I spotted 2 whales very close by. It was about 1.6 kilometers in the water, and I got this nice footage with my drone. But yeah, if I probably was sitting in the sun and it was in my eyes and burning, and I probably would have missed this opportunity. And I think that goes hand in hand with using rubber dam in your practice. Albert Einstein said that doing the same thing over and over and expecting a different result is insanity. Now, the same goes with rubber dam. And for any new thing in your practice, you can't do the same thing over and over and expect a different result. If you want to really up your game, and I mean 20% of your clinical work, I can promise you tonight that if you start using this religiously, from fissure sealants, from restorations, you will have so much more joy, but also so much more success and predictability in doing this. And the same goes for irrigation, the second lecture, which we will touch on to. If you want at least a 20% increase in your success rate with endodontics, I can promise you, start using rubber dam religiously. So, Yolanda, if you can come on stage and maybe share the first poll with us, you can quickly share it and then you can hand over the results.
Doctor, can you hear me?
Yes, I can hear you now.
Yes, so
Did you
I
manage
think
to run the poll? Sorry, because
yes,
I couldn't
the
see it.
poll
I don't
is
get any feedback on the sound.
yes, the poll is run. So if everyone can go to the poll where the chat question poll and people is at the top, the poll is loaded
Okay,
on the
right.
poll column. Yes,
Okay,
100%.
so I asked the questions, what, and I can tell you the reason why I asked those questions, and specific the one, because I don't know how to use it. And it's very bad for us coming out of university and really confirm or agree that we don't know how to use rubber dam. Because I honestly didn't know. 10 years ago, it wasn't part of my practice. I didn't know until I was told how to use it and really the basics. So I can tell you 4 things why I use it. Firstly, to reduce stress, and meaning the stress not just for the patient, but for me. If you want the patient to be relaxed, it's amazing. I can tell you, I can build my whole practice around this. It's a success of story, handing the patient a mirror. It's amazing to see a patient stressed and that he can't breathe, and all the stories that tell you of hate going to the dentist and walking out after the treatment and say, yes, that other thing was nice. I probably, if there's 1% of patients that don't agree or don't like it, it's probably the one that doesn't apply to anything and it's always complaining about something in my practice. There's a simple restoration I did this week, or was quite big. I could work for 40 minutes, building up this tooth, prepped it ready. You can see how dirty it is around it. The problem is with a patient that's not relaxed as well, is as soon as you start using etchant and anything flows to the throat, it scratches the throat, they get itchy, they want to cough. So look at the difference in this after I've treated it, after 40 minutes of sitting like that, and now trying and do the same thing. We did a restoration. I had to extract the 3/6. There's no ways with cotton wools, with mirrors, with suction tubes that you can get that area to stay dry, no matter how good it is. At one stage, your patient is going to tell you, listen, it's quickly want to swallow, or he wants to close, or I can't keep my mouth open anymore. It really reduces stress for yourself and for your patient. You have one hand free that you can apply on something else instead of wrestling with the tongue the whole time. I told you that it relaxes the patient. I can't tell you how many times I do endodontic treatments and my patients end up like this. I don't know if you can hear the sound. This guy is snoring away. I couldn't believe it, and I took a video of the cell phone, probably unethical, but I couldn't believe that someone could be so relaxed, sleeping away without dormicum, and that happens often, that people will give a little snore or just, passes away because they are relaxed. There's nothing they can do or talk about. They relax and they sit down, and you can focus on your work and doesn't have to do this. It's an uncluttered working field. I mean, look there on a 3/8. If you have to do a restoration there, you have the whole time, the tongue is in your way. I have to wrestle with the cheek. I probably nick the tongue once or twice if I'm trying to do that. Instead of just sit back, relax, place your dam. You have one hand free all of a sudden that you can do something else just by applying it. If any one of you are interested in getting more efficiency in working with magnification, it improves your efficiency because you're working in an enlarged field. It focuses your view in. So now I can focus at the work on hand. I don't have to worry about the patient, cheeks, tongue, etc. And I can zoom into what I actually want to do, especially with restorations for endodontics, where it's small structures that we work onto. It really makes the learning curve so much quicker if I apply rubber dam. And it saves time. All the time that it takes you to place a rubber dam, you save throughout the treatment. So by saying, no, it's going to take time, or my patient won't like it, that's not anything to discuss about, because I can promise you, your patients love it and you will love it. And there's no way that I want to work in a mouth full of saliva and gunk. And even for yourself, I don't know when last you tasted the acid etch on your tongue, or chlorhexidine, or the small particles of an amalgam filling that you drill out. All that causes irritation in the throat, and a patient when he started to be unrelaxed or he's jittery, he's going to stay like that the whole time. Patients that gag, very good success rate with patients that gag. So for me, the time spent in doing it, and we'll talk about different things on how you can apply it in crown preps. For instance, you're prepping a crown. How many times through a crown prep is your patient asking you to stop, just quickly want to swallow? Where with this, you can sit down, you save all the time, you learn how to move the patient's head, you can look through the contact, all by applying the rubber dam, right from the start. So what tools do we need? Well, we need a plan, obviously. First, how are we going to do it? You need a pen, you need a frame, you need a punch, a template, clamps, and obviously the rubber dam. And I'm really going to keep this simple, though it's elementary, because I believe the people that's watching this are hesitant to use rubber dam, and that's why they're attending this webinar. So all the nice things you see, or the advanced stuff, there's links for that, where how they place all these floss around the frames. If you start out, keep it simple and get confident, and slowly build up your confidence so that it becomes a religion. So there's obviously different dams on the market. One from Hygienic, which is nice. The one from Coltine is a Ruco. It's a non-latex one for patients that are allergic to latex. Only downfall of this, it tears very easily. And if you do retreatments in endodontics, if you place chloroform on it, it eats it away. So be warned. Whereas with the other rubber dams, I don't find chloroform to have any effect on them. A nice new rubber dam from Romulus is Dammit, very reasonably priced, and also comes in a non-latex and a latex one. My probably favorite rubber dam is Dermadam from Otterdent, the non-latex one. It is more expensive, I agree, but I really like the softness of the dam, and the color obviously very nice for photography. So what dam do I choose? Because you get a thick, you get a medium, and you get a thin one. Well, I would go for a thin or a medium. Stay away from the thick ones. It's really maybe only for single tooth isolation, where it's helpful if you do endodontics, but if you have to floss through teeth, you tear them, or they tear, it's very difficult to place, and these corners of your patient's mouth, it stretches a lot, pulls on the lips, where this rubber dam, I really find it to be very soft, very flexible, and it doesn't tear as easily when I place it. All these fancy ones or small ones, I guess they're all okay, but in a general sense of endodontics, for small procedures or maybe anterior, they can work. But we are here to speak about rubber dam and using it religiously and really placing it in different way. I don't have good success with these ones. They tear easily, and especially with last restorations. For anteriors or for children, maybe yes, they can work. Handy dam, which came out from a Septica, used to employ it for endo, for one tooth isolation, but not really for restorative dentistry. And we stick to the basic, just rubber dam. Then you're going to need a frame. Well, something small like this, a hygienic one or a metal one, that would be my go-to. I found these plastic big frames to be uncomfortable. They tear the rubber dam. It tends to shear right on the patient's chin with that sharp edges, and it's just not uncomfortable. If your dam isn't put on, very comfortably, the patient is also edgy. So you want your dam to sit in a nice, comfortable position for your patient. Obviously, you need a nice forceps clamps, one that is long tines, and you need a punch, a sharp punch, and that's the basic tools that you're going to need. And then we're going to need some rubber dam clamps. So if you buy the whole kit, you're probably going to be stuck and wonder which one to use and when am I using which clasp. And that's probably why we stay away from using it, because you buy the kit and you get confused. And the problem with rubber dam is the first time you place it on your patient, you clamp the wrong teeth, the dam tears or it jumps off, the clamp is back in his throat or out of on his chest, back goes the rubber dam into the drawer. So I want you to become confident in using it, and I'm going to show you a few tips that worked for me. And I'm going to say it straight from the beginning. Rubber dam is for-hand dentistry. It's not a single-man job. It is something that you and your assistant have to learn together to use. Then you will have joy out of it. She must understand it, she must buy into it, and she must put it straight there with every case. It shouldn't be lying in the drawer there where you have to stretch for it and look for it, because that's when you start, I can quickly do this restoration or this fissure sealant without it. So I would buy an anterior one, maybe a hygienic like this one. And the confusing part is which side goes where. Well, you will see there's a narrow area and there's a wider diameter of this clamp, and the wider diameter goes to the inside of the mouth. And there's an anterior tooth where it's been placed. Also, you can place it the same way as this for premolars, especially lower premolars when they are severely broken down and you struggle to get retention. I use this sometimes, turn it to the side, and I can do build-up or restoration or endodontics in a lower premolar. Then this B4 brinker clamp, very nice for alternative retention, very nice on the anterior small little teeth, or when you're placing veneers or cementing crowns as an additive in the anterior region. I found them very helpful. Premolar clasp, hygienic, number one, or Euphridia one that has these little tiger clamps, they call it, little tines that just engage nicer in the tooth if it's not fully erupted and it keeps on jumping off. That's it. And then I would buy 1 or 2 molar clamps. I do like these ones from time to time. If you get a 12A and a 13A, so you will see the one side is smaller on the inside, lingual side, and the outside is broader, but you get the reverse one as well. And you can sometimes turn them around when, for instance, the buccal cusp is fractured and you want to turn the clasp to the other way so that it engages on the fractured down portion. Probably my favorite clamp is a clamp that looks like the Septica number 5, 4 molars for single tooth isolation. I'm not sure if you still can find this clasp, but look for something similar to that. And that's basically the clamps that I would buy. I would buy a frame, I would buy a punch and all that. If you invest in the whole set, you're probably going to end up, a lot of them, you're not going to use them, but also it might be cheaper. And I was quickly looking at the specials that are running tonight, and you'll see here in the corner, this number 14A, that might be a good molar clamp to buy. And then the last one that I would invest is this PW from Ash. It's a wingless clasp, so there's a difference in applying it, where you would probably first place the clamp on the tooth, where the others, you will place it in the dam, and then you stretch it over your tooth. It is nice, angulated towards the side, so it gives you better access when you look through a microscope, for instance, and it engages very deep down underneath the gum, sort of. So for severely broken down teeth and for restorations, I found this to be a very nice clasp to use. And there is a way to place it in the dam by just let the back portion stick out, or you can place it on the tooth itself, click it over, and you will floss it to the front. And I will show you my sequence of how I place the clamp and how we floss it together, and so that you can become more comfortable in using this on a day-to-day basis in your practice. Then also this plastic clasp from Kerr, a soft clasp. What is nice about it for endo, for instance, it is not as radio opaque, so you can see the tooth, or if you do measurements. And I found it very nice for pediatric dentistry. And I really, not with all children, but if I see they are compliant, I always tell them, listen, I'm going to place a little raincoat over your tooth and we're going to work. I can tell you a lot of children, you'll be surprised because they don't know what to expect. Their parents are scared and they tell them all the stories. But if you make them believe and buy into it and you show it to them from the start that they know if they come to the dentist, they are going to get a raincoat over their tooth, you'll be surprised how really relaxed and compliant children are. And you can place it on children, nice for pediatric teeth, and also maybe if it's a temporary crown that's on, it's not as aggressively like some of the metal clasps. So that's the basic clamps that I would have in my armamentarium. And there you can see the 13A, where you can change to place it on the buccal or the lingual portion. Clamps wider here on the gums. I will place the dam underneath the tines, and I have enough workspace that I can do laser, that I can place my band, build up the tooth, and get it ready for whatever is going to be done. In this case, it was a lower 3-1, 4-1 that I was busy doing endodontics on, and you can see I used a premolar clasp, turn it to the side, place it over it, and place some liquid dam around it. So there's different ways of using it, and it's like any computer program that you work on. You have to work on a computer to learn the program, and the same with the clasp. There's no right or wrong, and the patient is now place them, play around with the clasp, and you will soon become more accustomed and look for ideas for yourself. Remember, no mouth is the same, no tooth diameter is the same, and sometimes you have to think out of the box, and then you can use a situation like this, one clasp, and you can clamp the two teeth together. Or you can use the pre-loaded clasp. And remember in the beginning I said we need a plan. So where do I clamp? I always try and clamp as far back as possible. On a 1/7, on a 3/7. Even if I work on a premolar, even if I work on a canine, I would clamp the 7. It gives you more space to work in for the water to flow back, and just makes it easier when you work with the patient. In cases where I do build up, say in an anterior, you can place it on the two premolars. Then you can apply floss around each tooth, tighten it to pull it in, or take your 3-in-1 syringe to invert it. But this is the basics of the plan that you're going to employ. You will sometimes have teeth which have big gaps between them, or the dam keeps on jumping off, and you can employ, you have a PW on the 6, and I'm using the 13A on the 7. So there's different ways. There's not a fixed set of rules, but with this few clasps, I can chop and change and maybe think out of the box. And then obviously I need some opal dam that I place around it specifically for endodontics, where it increases the accuracy of your apex locator reading. You don't want the patient to swallow any sodium hypochlorite or Rexidine or EDTA when you work on him. And also you want a dry field if you do fissure sealant or any composite restorations or crown preps or cementation of a crown. You can apply this to keep any clavicular fluid out of it. I hope that everything is still fine and you can hear me. Sorry, I have no feedback. I don't see anything else except the screen. Yes.
Dr. Heinrich,
Yes,
apologize about earlier. If you would like, I've got the results of the first poll.
Okay.
Would you like me to read it out?
Yes, you can quickly read it out. Thanks.
So the question was, why don't you use rubber dam? 16% of the audience says that my patient won't like it. 26% of the audience say it takes too much time. Majority of the audience says, I do not feel confident to place my rubber dam. And only 5% of the audience said that they bought it due to COVID.
Okay, thanks. Very interesting. And that's sort of the idea which I thought, you think your patient won't like it. And I can tell you now, if you're not confident in placing it, your patient isn't going to feel confident. But if you explain to them, you relax, you know what you're doing, and you tell them the steps, and you give them a mirror and show them, the patient all of a sudden relaxes. And I can tell you, 90% of the time people walk away and say, wow, that was a different experience. And the same, we feel ashamed. We don't want to confess that we don't know how to place it because, come on, that's the first thing we should know. What we haven't been taught at university, we probably didn't have all this armamentary at our dispense. And I can remember when we placed it on those phantom heads, they were difficult to floss in, and then we struggle in a tear, and that's the same that happened. You have to be confident or get your assistant, your receptionist in, and try it, or try different things, and that's the only way to learn it is stuck it in, put it next to you, and start using it. So in Afrikaans, soos Robbie Wessels sê, die leeu loop, ons gaan hom nou stap vir stap verduidelik. So ek wil julle verduidelik, I want to show you the easy way to do it step by step, so that after this webinar, that you can really do the basics right. And from there onwards, build your confidence to do it more advanced. This is alternative retention, or you can use wedges like this, little stretchable rubbers. You will see them in some of the slides, or you can use a normal plastic wedge in between the teeth. It would look something like this. And this typical case without a clasp, just by placing wedges in, look at a clear field of view. I was busy doing a retreatment fiber poster that I moved. It focuses my work, or focus my eyes on where I want to look at my work, at my endo, at my restoration. I don't get sidetracked by the lips, by the patient's tongue, or closing in between. I can really focus on my work, and that lessens the stress on yourself and on your patient. If you don't have a rubber dam that sits comfortable for the patient, for sure they're not going to like it. If it sits over their nose, or they feel claustrophobic, you just need to show them that, listen, you can breathe. We're going to place it in. This is where forehand dentistry comes into play, that you and your assistant do it as a team. When we place a rubber dam, this is what it must look like. Away from the cheek, away from the chin, away from the nose, and in a comfortable position, so that it's not sitting to the left or to the right, but it sits in the middle. How do we do it? Because otherwise, that's where we get stuck. We place the first dam, it's sitting askew, it's pulling onto the side, and yes, your patient is going to like it. And what do you tell yourself? Well, I'm not liking it because the patient isn't liking it. But you have to stick to your guns. Give yourself 3 days, practice it. After the 5th patient, I can tell you will become more and more confident. Maybe start with just single tooth that you isolate and work yourself up to be confident to do quadrant restorations. So how do we do a single tooth? Probably for endodontics, and I've emailed these templates to Yolanda, and you can email her, and she's welcome to share this with you. And you can laminate it and keep it, and my email is on it, and there's always, if you have any question or I can help, please feel free to email me. So I can't make it more simple than this. This is a single tooth isolation only. So I'm doing an endo. I'm going to work on the upper 3. I would place my dam right on this, make a hole right on that dot. So you take a cookie pen and you place a dot. If I'm using work on a upper 6, I would place it a little bit down. So my dam gets placed right. Sorry about that. So you place your rubber dam straight in the middle, and you will make the hole. If you work on a premolar, you're going to mark the dot and you punch it right there. If you work on anterior or on anterior teeth, if you work on mandibular teeth, you're going to make it straight in the middle. No matter where you work. If you work on the back, 7, 6, 5. If you work in the anterior, 3, 1, 4, 1. You make the dot right in the middle. That's where you're going to punch the hole. And then you obviously select the clasp for the case that you're going to do, whether it's a premolar or a molar. If I'm working in the mandibular, like I said, place the dam in the middle, make the dot, punch the hole, and it can't get more easier than that. And then you can add a little bit of flowable just to keep any clavicular fluid from coming in, or any fluid or any foreign objects from going through. Then you will see on these clasps is something that I custom made. You will see there's a little groove, because that's the other thing that happened. As soon as you try with the probe to flick it over the wings, you're going to tear the dam, and you're going to use 2 of them, and then 40 rand is down the drain. Back goes the rubber dam kit in the drawer. So you take the clasp, you take a drill, and you just make a little groove for yourself. And that's where your probe is going to flick the dam over the wings. Remember, this is winged clasp. The PW is a wingless clasp. So you make a little groove for yourself and you polish it. And I will show you now, step by step, how we're going to place the dam on. I know it's elementary. I know this is basic stuff. This is why we do this, so that you can become more confident. Read any instructions of any bonding of any composite they will show you, or any cement. The use of rubber dam is advocated. There's a reason for it. So let me talk you through this. I place the clamp in my dam, and I will show you a case later clinically. It's the little grooves. Take my probe, flick it over. I stretch the dam, and I place my frame on it, and you can add that. So just to maybe do it again. The clamp is in my dam, place it over the tooth. I'm working on a lower premolar, so the punch is right in the middle of the dam. Flick my rubber dam over, and I'm going to place my frame. And there I have a perfect environment where I can do irrigation, where I can work and do the work with confidence, predictability, relaxed patient, and you are relaxed. I mean, your apex locator work, everything works. If I do endodontics, I start with a rubber dam and I take it off when I'm done with the case. I don't take it off for x-rays. I would just take the frame off, fold it towards the side, take my x-ray, back on goes the dam. That dam stays on until I'm done. So I can do irrigation, and we'll chat about irrigation in the second webinar. And that's how easy it is with single tooth. So what about quadrants? Do we place it in the middle? No, we don't. I also mailed this to Yolanda. So if you buy a kit, they normally come standard with the kit, and then you have a template. But this is one that you can feel free to copy and laminate it, and you can use it. My advice is to always take it, I would say, 1 centimeter to 1/2 centimeter down and towards the quadrant that you are working in. So if you work on the first quadrant, bring the dam a little bit downwards on the template and 1 centimeter towards the quadrant that you work in. If it's in the lower, I would still bring it down and towards it. Then when you stretch it, you found your rubber dam really lines up better and not sits over the patient's face. Remember, we said we should have a plan. So I always try and clamp the 7, and I work my way forward when I place it. So this is the steps that I would follow. First, I punch a hole marked from my dam template. I place the clamp in my rubber dam, outside of the mouth. Then I place the clamp back on the tooth. I flick the dam over with my probe or a flat plastic over the wings. Then I place the dam over the frame, and I'm going to show you a whole video now. Start at the bottom, and then at the top, and then maybe at the middle. And you and your assistant must work as a team. She mustn't pull on the top and you pull on the bottom, or she pulls on the middle and you pull on the bottom. You start at the bottom one by one, stretch it over. It's like making a bed. You start at the same end, again go to the top. Otherwise, if you don't synchronize, you're going to pull it skew, and that's when the patient starts coughing or gagging, and then you won't like it. Then we floss from the front to the back. That's what I found works best for me. And another tip that is when you floss it through and you see the dam doesn't want to go through, the floss is through the contact, but not the whole of the dam. Don't pull the floss back out and reattempt it. So my assistant will always give me 1 or 2 pieces of floss ready. So I will floss it. If I don't pull it through, I will keep it there, take another piece of floss. And that's probably one of the best clinical tips I can give you, because this is where we struggle and we throw it away as soon as we tear the rubber dam. Take another piece, floss it through, pull both of them out towards the side. Let me quickly share with you this video. So we're going to work on in this case, we punched a hole in the 6. He didn't have a 7. And outside of the mouth, I would, and look at the hands. We're working with 4 hands, me and my assistant as a team. She pulls it because it helps me. And even when she punches the holes, I keep the dam for and we pull it together and we punch it. It just makes it easier. Then I place the clamp outside of the mouth in the dam over my wings. Okay. Now I take the clamp forceps. And another very important thing is when you place it, make sure that you and the assistant stretch the dam so that it doesn't engage between the tooth and these tines, because sometimes you get that it clamps or it grabs the dam and then it jumps off. So make sure that the clamp can engage on the tooth structure and not have rubber dam trapped between the clamp tips, the clamp and the tooth. Okay, so place the clamp in the dam, stretch it, make sure. Now I take my forceps and look what we do. So I try, this is where your patient isn't going to like it. If you let the dam fall over his nose, he's going to feel claustrophobic. So make sure that you focus on that, you and your assistant. Look, the whole time she is helping me. I would place the clamp over the tooth, making sure that with my other hand, I keep the dam away from the patient's nose. There's my dam. You will see it lines up more towards the middle. If I do it by placing it a centimeter down, centimeter to the right in this case. Next step, flick the rubber dam over the wings. Otherwise, you're going to pull on the dam, it's going to pull off, and then, sorry, I don't like rubber dam. Or you tear the rubber dam when you do this, or the rubber dam is too thick, then it hurts the patient on the corner of his mouth. So flick it over. And then what you can do if the contact is very tight, I sometimes feel the contact before I place it, is maybe put a bit of KY jelly on the teeth or underneath the rubber dam so that it also flosses easier into it. Now we take the frame. Look at my other hand. I'm still keeping the rubber dam away from the patient's nose. Otherwise, he gets claustrophobic. You haven't seen once that the hands of my assistant or mine slip. We work as a team. She's pulling on the corner, I'm pulling on the corner. We would flick the dam over, because they are illustrated. If I'm pulling on the opposite side, it doesn't align up. So we're working in tandem, we synchronize middle, top, and there you have the dam. And if it sometimes end up being on the patient's nose, I will take this and just flick it away towards the inside. You will see now, I'll make sure that it can breathe. And then what I told you, start flossing from the front. Again, look at the hands. It's a team effort. My assistant must pull the rubber dam to stretch it so that it's thinner, so that I am able to floss it through. She's holding it there for me. You can't do this on your own, otherwise you won't like it. There, I pull it through. I pull it towards the side. It's going nicely through. Pull it through, and then you will have 1 or 2 where you will pull it through, and you will see my floss just doesn't want to go through, or the floss goes through, and you can see it didn't take all the dam with it. So a lot of times, if you pull the floss out again, it pulls the dam out with it. So keep it there. A very good tip this. Take another piece of floss, and then you make sure both of them goes through. And there's your rubber dam placed. Away from that, and I flick it away, from the patient's nose. And that's how easy it is. But importantly, it is a team effort. You and your assistant must work together to do it. So here's another small video, and then hope you still can hear me all. Put it to the side. Punch the holes.
Dr. Heinrich, thank you. Everything is still very good. Thank you.
Okay. Right, again, same scenario. Going to forward a little bit. Place it on the back tooth, flick it over, floss it through. My assistant is helping me. There you can see typical what happens. Is the dam that it pulled through. I'll take another piece of floss and just reapply another piece, then pull it out towards the side. Otherwise, it pulls back together. So what about cases like this, when there's nothing to clamp onto? Well, this is what's going to happen. You don't need to have it engaged around it. There is different ways. You can put a lot of flowable dam around it, or simple trick, you take a bit of super glue. It does nothing towards the gum. It doesn't irritate it. I cut it through. I use this method a lot when I do class 5 restorations. Place a small drop of super glue, normal super glue that you buy at Spar or Pick n Pay. Place it on the inside of the dam. Take a ball burnisher and just dab it onto the tissue. It will stay there. You can do your work. Here I'm placing retraction cord. I'm working with a dam in a dry environment. And then in the end, you just peel it off. This tooth is going to get a crown. Or you do split dam techniques. If you're going to do a crown tape, for instance, or there isn't retention, clamp the back tooth, clamp it, floss it in the front. Here I'm doing a crown prep, and you can see I just cut the dam in the middle so that it's engaged in the front and the back. It's all about moisture control and a clear environment in which I can work without being distracted at the work that I'm doing. Typical class 5, difficult to do, as you know, with lips here. I cut it, I'll glue it, or I keep it away, and there I can do a class 5 restoration under rubber dam. Cases like this, I'm prepping a crown. You don't need to bond it, but it's easier to keep my mirror there than wrestling with the tongue. You can see my the enhanced field of view. It's not distracted with tongues and cheeks and everything else, and the patient that's coughing. And the time that it takes you to place it, you're going to win. If you do a restoration or a crown prep, for instance, you place rubber dam, you will see that you are going to save time. I can't work without this. Another clinical tip maybe is when I inject it, I keep my cap, especially for an endo, on the bottom. If you place rubber dam, the clamp is there. And we work with long procedures, and you place a bite block for the patient in. His tongue is numb, the clamp is there. It just becomes too much in the mouth. So a very good tip for restorations or for endo is I take the cap, I cut the top piece off, and I place it over his 2 canines, and it gives him a nice support. His tongue can move freely, and it just gives him a bit of suspension so that his jaw can relax when I work. There's another case. I was building up this bottom teeth, place a little cap on the canine on top and the bottom, and it's very nice and stable, but it's not hindering for the patient, and his tongue can still move freely. Here's a case where I'm doing an inlay or an overlay restoration, and you can see a clean working field, air abrading it, placing plumber's tape. I have absolute control, and it's about control which makes it predictable and which add to the success. I hope that was easy enough. I know it's not scientific. That's not what we are here for. We've done that enough. That's the clinical tips. That's what worked for me in my practice on a day-to-day, religiously placing it. It's about practice, 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 and you will become more confident in placing rubber dam. And the last take-home message in this is it is teamwork. It is forehand dentistry. Don't attempt this on your own. That's probably where you've been lacking. That's probably why you don't like it. Why don't you don't get joy out of using it? Because you struggle. If you and your assistant learn it together, you will both enjoy it. Your assistant will also appreciate you for using rubber dam in your practice. Thank you. That was the first lecture.
Dr. Heinrich?
Yes.
Your lecture is so good. There's not a lot of questions, Some more than one person said awesome cap tip. Thank you for
Thank you.
that. And they also say thank you for the positive attitude towards Rubber Dam.
100%. Thank you very much for that comment. Can we go straight on to the second one? I know we are pressed for time, and that I hope I'm all clear. I must say it is very, it's not a very nice experience. We sit and watch at your screen the whole time and you need to speak to yourself. But I hope I'm clear and everyone can see me. And yeah, so yeah, are we ready for the second one? Just take a sip of water. Or probably should have been a cocktail. So again, I was asked, please, can you help us with irrigation? Because a dentist, they buy the stuff, they don't use it, or they're unsure where to use it, when to use it. And this is why we have this webinar tonight. Again, there is science involved. There's lots of scientific evidence, but it's still maybe a topic that's tongue in the cheek for some, and I'm going to try and highlight it out of a practical practice perspective, where I use it every day, and how I use it, how I implement it, and I hope after this lecture it will make sense for you. So if you read articles, you're going to get articles for peroxide, for ozone water, for chlorhexidine, for sodium hypochlorite, etc., etc. And it's a cocktail full of things. And if they are packed like this, then full of fruit and nice things, maybe, you know, they could do the trick. But you have to know which one to use where. And if you use all of them, maybe you won't remember what you did and how you did it. So maybe stick to one or two, and that you are not over the limit to drive back home. So the first question I always ask when I do irrigation lecture is, can you tell me which of these files kill most bacteria? And strangely, there's people that would say maybe it's wave 1, maybe it's ProTaper next, depending on the file system they use. But come on, people, we know that a file can't kill any bacteria. A file is there to prepare a canal so that there's an optimum space in which I can irrigate and can obturate in. That's the only difference is one file can do it faster than the other, one is more flexible, but that's the method, and that's the purpose of a file, to get it to length so that I have an environment in which I can irrigate, laser, rinse, obturate, and seal the case off. If I take this case, for instance, a bizarre case that was referred to me, was actually a dentist patient. I did a CBCT scan and I was unsure about what I'm looking at, because I thought at one stage there was maybe a piece of a wisdom tooth that was stuck there. Look at this as I scroll down on this bottom portion. Look there, you will see all of a sudden a piece of tooth appearing there. So it was really strange. I couldn't get proper patency, and that's what happens when you work on family, friends, and colleagues, as you know. Quite a difficult case, and we irrigate and treat it. She was with another dentist in practice, and they also attempted, so it was a difficult case to start with. You can see files are bending, and then you get to a stage where you say, well, that's what I can do now. We irrigate, and that's my go-to. If anything happens, if a file fracture, I go to aggressive irrigation, because in the end, I believe that's the success of long-term success of endodontics. There's a lot of contributing factors, but probably one of the most important ones. And there was the end result. By luck, I managed to get clean lateral canals in the bottom here on this side, only with good irrigation, where I couldn't get down, couldn't get patency. And this cannot be done with any file. So none of the success of this treatment is due to the fact of any file. It was a bizarre case, and with good irrigation, you sometimes by luck will see this happening. So let's look at a tooth as a little tortoise. I need to take this tortoise to a washing bay or an endodontic procedure, and I need to clean this out. I need to make it free of germs, I have to get rid of all the crevices, all the gunk that sits in these little crevices. But I also have soft tissue that I need to get rid of or clean. And I have the little eyes of the tortoise that I have to be gentle with, because I can't place any fluids in there. So that might be the periodontal ligament. I have hard tissue inside the tooth. I have organic and inorganic tissue, and I have a periodontal ligament to think about. And if I want to clean this properly, I have to protect the eyes. So I have to protect what I do. So how do we do it, and how do we try and make sense of irrigation? Well, Sergio Cutler, he's one of the developers of the Wave 1 gold system as well, did an interesting study where they took about 400 lower sixes, they cut the distal roots and they scanned it, CBCT or CT scanned them, superimposed it, and this is the type of images they came up with. So this is what we are treating when we do root canal therapy. We're working with a whole biological system. We're not working with 3 white lines on an X-ray. There's little anastomoses, little crevices, and splits canals, which sometimes no file can attend to, and there's bacteria that hide inside there. This is what we're going to treat. And how are we going to treat it? Because a file is only a little bit of the equation. To get a space in which we can place our different cocktails in to get rid of the bacteria, so that we can obturate it properly in the end. So Beruti and Castellucci in 2005 said, what are the other properties that we are looking for when we're using irrigation solutions? It must dissolve proteins of necrotic tissue. It must have a low surface tension so that it reaches the deltas and all those little crevices and areas that we can't reach with our instruments. It must lubricate the canals for instrumentation. It must have germicidal and antibacterial properties. It mustn't be toxic or irritating to the periodontal ligament. It must keep the dentinal debris in suspension. So we're looking for this gummy berry juice, this one cocktail that we can use that will tick all the boxes, that we feel good, that we have a good time. If it's cocktails that you're after, but we're speaking about endo, but that one cocktail should have all these currents in. It must be readily be available. It shouldn't be expensive. And that's the 9 things that they set out that the ideal solution must have. So what are we working with and what do we deal with if we work in endo? Well, we have the anorganic part, the chips of dentinal tubules and dentinal mud that we create when we do instrumentation. We have calcifications in the canal or a pulp stone like this. So we have the hard stuff and we have the soft stuff, the necrotic tissue, the artery and the nerve inside the canal. And we have to deal with both of it. Plus we have bacteria sitting in the canal and in dentinal tubules. And that's what it looks like under high magnification. Bacteria growing on the sidewalls and into the dentinal tubules. Enterococcus faecalis, a very aggressive bacteria, very tight or hardened and very difficult to get rid of. So yes, I saw this on the internet when I was doing preparation for this webinar, and it was quite laughable. Before and after of cocaine. And what you look like after, before and after for alcohol and using crack, and the before and after of using sodium hypochlorite. So that's the first liquid that we are going to speak about. So the ideal situation before obturation. Yes.
Dr. Heinrich, apologies. Should I ask the question now?
You can.
Okay, there's a question, Dr. Dippenaar. The concentration in sodium hypochlorite, is it sufficient in jig or Milton? We also use EDTA afterwards.
Okay, thank you for the question, but I'm going to keep the answer and it will be clear in the next couple of slides and we'll answer it. I'm going to deal with every solution, concentration, and how we're going to apply it. And I'm sure, sorry, I don't know, got the name of the person who asked the question.
Yes.
Who was it that asked the question?
It's anonymous.
Okay, no matter what, I think there's a lot of questions and that's why we're looking at it. Doesn't matter, but you will get the answer while listening to the next few slides. So Dr. Marcus Apesalo wrote a very great article on the irrigation solutions, and they also confirm there's no single solution that's sufficient to tick all the boxes. We're looking for the gummy berry juice. We're looking for that one solution that ticks all the boxes. But with all technology at our hand, at our disposal, at this stage, there's not one solution that does all. You have to use a combination of solutions and techniques maybe with irrigation. And that's the purpose of this lecture. So I was fortunate enough to write this article with Prof. Piet van der Vyver that was published in 2015 in the Odontic Practice magazine of America. And it's still a relevant topic. You can Google for it, or I can forward it to you. But it's things that have changed ever since. But the principle stays the same. We want clean dentinal tubulars. We want canal walls free of bacteria, free of dead tissue and muck, so that we can obturate it afterwards, and then we should have longevity. Nice clean tubules free of any Enterococcus faecalis or endodontic toxins. Okay, Landa, you can run the second poll for me. And Anonymous, the question will is probably also what you were looking after, or the answer will come in the next few slides.
While she's posting the poll,
Yes.
there's two other questions with regards to rubber dam. Should I ask
Yes.
them now, or should
Please,
I wait?
yeah. They can. So yeah, make it. Do the polls quickly. Gives an indication. Yes, Yolanda, you can ask.
Okay. How and where on the clam do you put the floss as a leash?
To be honest, I don't put a leash, but you can place it about on the top portion. A lot of guys place it over that little tine where the clamp forceps goes into. On the buckle side, they would place a little floss for safety. But I've never honestly placed it myself. I guess the question is asked out of safety, that people don't swallow the clasp. But if you flick it over and it sits in position, if it jumps off the tooth, it normally is with inside of the rubber dam, and it's easy to get it out. And that's why it's sometimes a good idea to take a clasp, place it over the tooth, and just feel that it's stable before you stretch the rubber dam onto it. And also to tell your assistant that it shouldn't pull hard, because it's sometimes really like a ketty. We've had cases where you pull on it and the clasp shoot off. So but you can place it over the band, or you're in the buckle side of the little hole on the side of the clamp.
Thank you. And then while I'm waiting for the results on the poll, another question. Please speak a bit about the benefit of the plumber's tape.
Referring to the slide, I guess, where the plumber's tape is. The benefit of the plumber's tape was just there for cementation, so that I didn't place any bond onto the adjacent teeth, or when I place the cement, because I do the cementation under rubber dam, squeeze on it so that I can take it out with ease. That was the only benefit in that case, if that is what you are referring to.
If you don't answer the question, please feel free to tell me afterwards.
Please feel free. Address it differently. I hope I addressed your question. Do we have the answers of the poll? Just read them out quickly, the questions.
Quickly, when you need to replace an old crown on a second molar with no wisdom tooth posterior to it, how do you isolate it?
If we place a crown on?
Yeah, if you need to replace an old crown on a second molar with no wisdom tooth posterior to it, how do you isolate it?
Okay, it is very difficult, and in some cases I would use a product which looks like the Isolate Light from Inter-Africa Dental, Mr. Thirsty. You can Google it and look for that. Or what I do is I like to use the PW clasp, and I can sometimes take pliers and just bend the clasp a little bit outwards so that it engage on the gum itself. But you have to numb, say for instance, in the palate. And then I would place the dam over it and clamp then the gum and the gum, basically the gum and the the rubber dam together to keep it into position. So it will make a little spot there, and you can warn the patient afterwards that it might be a bit tender. Or if there's an area where I'm not going to prep, or I'm going to take it off later just to keep the clamp there, you can always spot it a little bit, place a bit of flowable composite just to keep the clasp in position while you prep, and then take it off afterwards. But it is a difficult thing to do, and that's where I also like to use the 13A or the 12A, so that I use the wing on the side where I can't get nice engagement. But there will probably be one or two cases we are going to struggle, and also this side of the mandible or the ramus going upwards, it can really sometimes patients have a bone that sits in such a position where it's awkward, and it engages on the clasp. We are going to struggle to place it, but I must say that's the exception.
I've got the results of the poll.
Yes.
What concentration sodium hypochlorite do you use in your practice? No sodium hypochlorite, 2% of the people.
Okay.
Molten, 26% of the people. 3.5% jig, 38% of the people. And full strength, 6%, 34%. So jig is the majority, then full strength, then molten.
Okay, great stuff. So run the second poll, and then we can speed it up. Just read the poll as well, because I can see it that I know which and which sequence it is.
The second poll.
Yeah,
would you
there's
like
another
to
poll?
the last question?
Yeah, you can do that one as well. Then we're done with the polls.
Okay, so we're going to run the last poll while you. There's the last poll. It's up for you. What other irrigation solutions do you use in endodontic treatments?
Okay.
Okay, so we'll just wait for the results.
Okay. Okay, so let's give it another 20 seconds, and then you can stop the poll.
Dr. Heinrich, after EDTA saline and then pack endo,
Alcohol or what?
after EDTA saline and then pack endo, let's just wait for her to elaborate on the question. Okay, let's see the last results.
Yes.
The last results, the question was, what other irrigation solutions do you use in endo? Majority of the people said EDTA. Then it was just sodium hypochlorite. Then it was a combination of above. And lastly, chlorhexidine, 2%.
Okay, great stuff. All right. So let's look at sodium hypochlorite. It's alkalic solution, very high pH. It has germicidal and antibacterial properties. In water, it produces hypochlorous acid and sodium hydroxide. And then it produces a byproduct of oxygen. So sometimes when you do fiber post, that's where it's a good idea to rinse it out with EDTA, or so that there's no free oxygens and it impairs the setting of the sealer, for instance. Also don't like to use that as my last solution. Some people rinse it with saline, but I use EDTA as a last rinse before I dry and seal off my canals. So there's different concentrations, as you pointed out, 0.5 to 6. It's potent active material. It kills bacteria mostly on contact. The only solution to dissolve necrotic and vital organic tissue. So if you take a little piece of, say, a 2-minute steak, you place it in different concentrations, you will we'll see how it dissolves it and how the one does it faster than the other one. It works better at 60 degrees Celsius. If you increase the temperature higher than 60 degrees, it inactivates it. So then you have to dispose it. Your sodium hypochlorite will be ineffective. So if you are using a heater, you can't place it in the morning and then work the whole day with it. You have to place new fluid in right at the start of your treatment so that it doesn't go longer than an hour. Otherwise, place new solution in it. It is time and dose dependent. The higher the concentration, the shorter the time needed to get rid of all the tissue in the canal. But the problem is it doesn't have an effect on the smear layer. So when you use your rotary files, you're creating a smear layer, you plug the dentinal tubules, and the only thing to get it out is obviously EDTA. But sodium hypochlorite can only dilute the little bit of tissue that sits on the smear layer, but it can't do anything about the anorganic matter that forms. So there's molten 1%, obviously, jig 3.5%, and then the core extra, or the pack inner, which is a full strength sodium, which is stronger in concentration. But this is dangerous stuff. We have to be careful if you employ this. You can't go from no rubber dam to using 6%. Do it in steps. If you use rubber dam, I can promise you're going to feel more confident to start using stronger solutions and maybe heat it up a bit. So how do I heat it up? Well, I use a baby warmer, for instance. The one pigeon, you will see that it can go to 100 degrees Celsius. Most baby bottle warmers only goes to body temperature, which is 37 degrees Celsius. You take one that can go and place it around about 40, 50, and you will see there's an increase in the dissolvability of the tissue that you are going to use. Or this one is the one that I use from Vista, which is around about 50 degrees where it heats up. You can place your syringes in there, and I use it for a composite heater as well. So there's a little slide where they place the tissue in, and after 2 minutes, you will see it is dissolved. So time, dose, and heat dependent. The higher the temperature, below 60, the stronger the concentration of the sodium, the faster I will dissolve the gunk in the canal. But this is an interesting study of Edgar Schofer, where he said sodium hypochlorite was found to be effective. A 1% solution at 45%, sorry about it, dissolved pulp tissue as effective as cold, full strength sodium hypochlorite at room temperature. And a 1% solution at 60% cells was as effective or than a full strength that's unheated. So there's a lot in the heatability of the solution, and maybe that answers the question. So it seems that you can use a lower concentration, which gives you a safety margin. By heating it up, it will become more efficient. So that's a give or take. It depends on how long we have to irrigate. The longer time we have, probably the lower the concentration can be. But I want to give it all, because I would keep my appointments a bit longer so that I have time to irrigate properly. A higher concentration with heat, and the longer I can irrigate, the better chance of success in my endodontics. He also said that a 1% and a 5%, after 30 minutes, both concentrations fail to remove it. Now you can think for yourself, if you use, you really irrigate for 60 minutes in your endodontic procedure, and a 2.25% solution used 60 minutes to eliminate Enterococcus faecalis. So there should be at least contact time of 30 to 60 minutes with the solution. So I hope that answers the question, and it speaks for itself. The higher the concentration, the better it will be in terms of necrotic tissue dissolvement and killing bacteria. But you can stay safe by using a 3.5. I doubt that I would just use molten, because it is really weak. It can have an effect if you heat it. But I would take, if I don't feel that confident, maybe normal strength jig and heat it a bit. And if you feel confident in your case, to use full strength and heat it up so that you can get better results by dissolving tissue quicker and get rid of bacteria. But now we created a smear layer and the sodium doesn't work. So we have to employ something else to get rid of that smear layer on top, which is full of ground dentine, pre-dentine, pulp remnants, and odontoblastic processes. So how do we do that? We use EDTA. So we want canal walls to be clean of inorganic and organic tissue. We don't want any bacteria, and that's why we have to employ this. And sodium hypochlorite and EDTA works symbiotically. It helps each other's effectiveness in alternating the two when you use it. The problem with EDTA is it doesn't have antibacterial properties, so we don't have a one bottle solution. It improves the effectiveness of the sodium if you alternate it. It doesn't make a precipitate. Sometimes you get a whitish precipitate, but it doesn't really make any downgrade on the case. Or if you look at your canal walls on your papers, it doesn't do anything. So I don't suck it out. You can clean it out, rinse with the next one, and you can use them by alternating it. It's a chelating agent, meaning it pulls the calcium plugs out of the tubules to open it up so that the sodium can do its bit on killing the bacteria. So sodium, think tissue. EDTA, think about smear layer. So there are different ones in the market, like Top Clear, which has cetramide, which maybe it gives a bit of antibacterial properties. Calicept, one of Calis, the one from Vista. All of them are good. And now Pack Indo also has one on the market, the 70%. So they all are good and they all will work. I doubt that the one is really better than the other as long as you employ it in your armaterial and part of your irrigation protocol. And I will give you my protocol and how I deal with the different irrigation solutions in the end. So let's go on. This is what we want, nice clean tubules, and then we can obturate. So what about chlorhexidine? Well, it's a very good antibacterial substance. We all know that. I use it every day on restorations. I wipe my canals full to create, to decrease metallic proteins. When I place my bond, it doesn't have a nice, as bad taste as sodium hypochlorite. Still not something I want in my mouth. It doesn't irritate the surrounding tissue. But it doesn't have any tissue dissolving capabilities. And it can't get rid of the smear layer. It gives substantivity in the canals that it's an ongoing antibacterial effect. So when you leave it in the canal, yes, it can contribute. Do I use it? No, I don't use it. One thing that you have to be very careful for when using chlorhexidine is if you take your 3-in-1 syringe, if it jumps in your patient eye, you can blind your patient because it causes erosion of the retina. So always wear protective glasses when you do endodontic procedure. You just take a 3-in-1 syringe and a little drop splashes in the patient eye and it can have a negative or a very bad effect for the patient. This is the problem with it. I don't use it in my endo treatments because it makes a precipitate with sodium hypochlorite. And go and test it for yourself. If you take sodium hypochlorite and you place a drop of chlorhexidine in it, you will see this happen. It looks like rust. It looks like liver paste that forms, and it's a sudden reaction. And there's even studies to show that it can be carcinogenic. And how are you going to get it out of the canal? If you flush that in a canal, it comes into contact, that whole case is stuffed, and you won't get it clean. So I stopped using it. Even though you flush afterwards with saline or EDTA, I stopped using it. So I mark my syringes always that I know which one is what. In practice, red is sodium and EDTA is the other ones. And I used to have chlorhexidine, but I stopped using it. There is another solution on the market which I employ. So I don't use EDTA. I use this product from Vista myself, which is called Smear Off. So the first thing that I did when I got it, so I mixed it with sodium to see if there's any precipitate. It doesn't make a precipitate. They don't say what the concentration is. So now I have EDTA with a little bit of chlorhexidine, but in such concentration that it doesn't form a precipitate, that brown rust precipitate with the sodium. So I can use the two in combination when I irrigate. Also now new is the one from Pactend. Honestly, I haven't worked with it a lot. So just check it beforehand. Maybe stick to Pactend if you're using it, or stick to the other. Don't combine it because you don't know what the concentration of the chlorhexidine is versus the sodium, and it might form a precipitate. But you can do that. Maybe suck it clean or take a paper pot, dry it, and then use it. So now you have the Smear Off or the Pactend Endo one, which you have antibacterial properties in combination. Okay, so we want to get rid of the bacteria and the smear layer. We want to disrupt the biofilm. How are we going to do it? After we just place it in the canal and we leave it there, do you think that we are going to get our canals clean? Well, for sure not. I need to use some device to activate it. Are we going to do it passively or with a device that can help us? And I always like to give something for everyone because we can't, there's new young dentists on the podium maybe, and they started out maybe this year or last year. You can't buy everything at one go, but what do we invest in? What do we use? So different needles on the market. Use a side port needle, like the MaxiProbe one from Dentsply, or the one from Ultradent is nice. This new Trinity needle, it's a nice polymer tip. It's very soft, especially for small canals where I only prep to a 20. It's nice also because it's spaced to the side. But I will show you my favorite device in a couple of slides. I am very scared, although I feel confident in endodontics, I am still to this day very scared to place a needle in a canal and extrude any form of sodium hypochlorite, because I don't want to end up with a sodium hypochlorite accident. So these ones, these navy tips, have a little brush on it, and they would believe that you could scrape the sidewalls, but if you look at the microscope, you will see these little hairs come off. So it's not something that I really like to employ, and I think there's better ways of doing it. So when I place it in the canal, there you can see it's a little brush, so you can irrigate and scrape the sidewalls on the same time. And obviously you have to be careful if it's sodium hypochlorite. And I'm showing you devices, and in the end I will show you how I'm using the protocol with the different solutions. So a very good basic tip is GP cone of your last preparation, cut the tip off, and I'm going to activate my EDTA in the canal by pumping it for, I would say, 30 times. So you count for about a minute per canal and you pump and activate the solution. You can't place EDTA or sodium for that matter just in the canal and leave it there and wait for something to happen. Maybe sodium hypochlorite on its own can dissolve tissue, can kill bugs, but you can cause a vapor lock and it won't reach the tip. So I need to stir and move it. So don't use this method with sodium because you might extrude some of the sodium through, or just keep it on the top portion and very slowly so that it doesn't engage right at the tip. But with EDTA, you can pump it and tap it, cap it 1 mil short of your working length and pump it in your canal up and down to get your canals clean. So, sorry, this is the endo activator from Dentsply, a polymer tip which goes in the canal and stir the fluids and activate it. Use it with my EDTA, very nice and gentle for sodium, so that you activate it in the canal. On that video which I stopped, it's little bubbles that explode, and it's the implosion of the, they call it implosion of the bubbles, that pop sound that cause the muck to get out of the dentinal tubules. Then this new one from ATIF, or the one from Vista, which we tested before it came onto the market, which is an ultrasonic device. It's a metal device. I'm not very fond of them because I think they scrape the inside walls. I like it when I work with the microscope and there's a piece of GP sitting on the side wall or a little pulp stone on the side. It's very aggressive in a sense, and you can activate that out. So I had to do a case or two of them and it was on their website. But when you look in the canal, not much happens. You'll see the bubble and you will see this debris coming out, but it's not as effective as some of the other stuff, like the activator or the eddy that I'm going to show you now. This is probably my favorite activation device. It's an eddy. It only works on an air scaler. So you have to have an air scaler, and you can get quite cheap ones on the market. With this, I haven't found anything that can activate as aggressively as this in a canal. So you will see it's actually very difficult to photograph or video this. It brings the fluid up, so you can stir it, and you can see if I step on it, I would step on my pedal up and down, up and down. You can see how it brings and move the fluid in the canal, circulate it, clean it, get gunk out of the canals. And this is how I do. So I will tell you the protocol now, but I'm just showing you different devices of how we do it. You will see it marked so that I stay clear from the working length. Look at this case, retreatment. You can see the little bits of GP shooting out. When I step on it, leave it. Look at the energy that it creates. It's very soft. It can't damage the sidewalls. And I found it very nice to work with my EDTA inside the canal. Look at how it brings up the gunk, upwards in a canal, and I can scrape it off. This is a method that I saw from Piet, and it works from Piet, that really works well, is to activate while you dispose it, and you get a stir, because when you place liquid in a canal and you place the eddy, within 10 seconds the canal is almost dry, because it activates so aggressively and it flushes the solution out. So you activate, and while you activate, you dispense liquid in the canal, and your assistant keep the suction tip, your normal suction, on the side, and you can get a lot of liquid through a canal. And it is by far the most effective way to get the smear layer and the canals clean, is to employ this. You can do it with sodium as well, but you have to be very careful in doing it so that you don't force it through the tip. But this is what I do with EDTAs. I activate 1 minute per canal with the eddy. Then there's another one from FKG, which is the XP Endo Finisher. There's a 25, and there's a R, which is for retreatment. Very nice to use in retreatment cases, or when I have strange anatomy or a very elliptical canal. I sometimes employ this. You can see how there's a bubble entrapment or a vapor lock, and how this can really clean on sidewalls or strange internal resorption cases, for instance. But be warned that you stay 4 mils clear from your working length, because it's like a little pigtail, and it expand and shrink, and it's easy to cause bleeding in the canal when you use it. But for retreatments, I sometimes use it. And this is a very nice thing to use, is when you do retreatment and with magnification, you see a little bit of GP right at the tip, or sometimes sticking through. I've had cases where I employ this and it will go through the tip, and because of that plugging action, it will actually plug the GP out of the canal. My other favorite device, I've been using this for probably the last 8 years, is the EndoVac. So I use the eddy and the EndoVac in combination. This is by far, for me, I still believe that this creates a lot of the success with sodium, with negative pressure, flushing and creating a stream of clean solution in the canals. Because if you take the same solution, activate, the solution gets dirty. Well, where this replenishes it and place new solution inside the canal, and you can circulate it right to the tip with great safety. And it was off the market for a while, and I'm glad that Milner's brought it back onto the market. And I think there's 13 kits available. So yeah, there's 250 people that registered. So yeah, you should start fighting now, or SMS Yolanda as we speak, if you want to be first in line, because I think they only have 30 kits left. But this, for me, is money well worth spent. I use these little things a lot. I don't use only one. I work quite a few cases with these little tips, and I'll show you now why I like the device and how to use it. So this is a case where I have a 1-year follow-up. This is quite difficult if you have a wide open apus like this, and you need to flush sodium hypochlorite down here. I had to place MTA in this canal, but if you look through the microscope in a case like this, which is quite straight, you can literally see the blood at the tip, and you have to be gentle. And the only way to do it safely is to take an EndoVac, mark it with a Koki, and I can place that tip right at the bottom, and I can circulate sodium hypochlorite with safety to the apex. And with the added benefit that it's new solution, and I can take a syringe within 4 minutes or so, take it and rinse it through. If it's a case that there's lots of pus draining, you can really sit there and you can get a lot of fluid circulated in a small time. This is the scary bit of sodium hypochlorite. You never push at the side of a syringe in a canal, because if you extrude a little bit, this is what your patient can end up with, and we want to avoid that at all costs. So this is what scares me in endodontics, and for me, that's why I use the EndoVac religiously. So if you first look at the device, it looks quite confusing, but it's actually very simple to use. So you have a big adapter that fits in your high suction volume, and it has 2 little tips One connects to the disposing syringe and the other one to the suction tube. This is why sometimes there's accidents that happen, and then you get phone calls of colleagues say, well, I'm in trouble, sodium went through, and they say, well, I stayed through, 2 or 3 mils clear of my working length, but a case like this, where it's broken through the bone, or there's sinus on the side, or the portal of exit is on the side, how do you know? You just might flush it, and you flush too much pressure, and you end up with a sodium accident. Or a case like this, the guy came in with trauma, took a CBCT, look there, the tooth was bumped right out of the socket. And now you have to do an endodontic procedure on this, and you might end up with extrusion because there's no negative pressure of the periodontal ligament around it. And the only way to get this successfully is to use an endovac. So this is how the system works. So you have your needle, the disposing one. So it has a short little needle tip which you can place in the orifice with safety so that you don't force any liquid solution down. And then that gets connected on the one side and it creates suction. So as the fluid gets pushed out, I've done it slowly, you can see how the fluid gets sucked up through that tip so that you don't overfill the canal. When you prep and there's a lot of debris in your pulp chamber, you place that in and it will suck it out. This is a nice illustration. When we did the article, Prof. Piet has a girl who does some great artistic work, and you can see here, so you have your tip placed at length, you move this up and down. I very seldom use the macro or the micro cannula. I only use the macro cannula because this gets clogged up very quickly. There's 13 little micro tips at the bottom. And you have to prep to a 30 or 35 to get this to length. So you just take this micro cannula, pump it up and down, placing liquid solution in the pulp chamber, and you get a circulation of clean solution with safety right through to the tip. And if you place too much fluid in the canal, you can see it's just some fluid that are stained, so I can show it, and you will see how it sucks it up so that you don't overflush the canal. And then you have the macro cannula, that was macro, and the micro cannula with this little tips at the bottom. It looks like a little needle, and you place it in, and you can cause suction by placing it up and down or just leaving it in the canal, flushing, dripping a little bit of solution, but it's not my go-to. I think for any assistant assisting us with endodontics, it can be quite daunting sometimes sitting there not knowing what we do. But if you tell me what we do, I'll forget. If you show me, they might remember it. But if you make your assistant part of it, they will understand it, and all of a sudden they also start enjoying endodontics. And here my assistant, you can see, is holding the syringe because that's the safety of using this device. By sucking it up and down and with lots of safety, I can get a lot of solution. This is quite an old video. You can see quite a younger looking me. So I've been using this for probably 8 years now. There's a screen that she can see, and you will see now, while I'm looking at the canals, moving it up and down, use the micro cannula in the canal most of the time. My assistant can help me, and yeah, obviously should wear safety glasses, but you can see how I move it up and down to get solution in a circular motion, and I can get lots of solution with safety right to the apical portion. I hope the video is not dragging. That's the problem with doing it over the internet. You can see I mark it with a Koki if it's an open apice and that I know my working length, and you can dispense a lot of solution, and moving it up and down, you can see how it takes all that clean solution out, and with a stronger concentration, heat it up, you can get much more joy out of the this is the micro tip. Okay, and you can see how it pulls it through. And you know, all these anastomoses, all those little crevices where it is important to clean, all 2 canals that merge, you can place it in the one canal, dispense it at the tip, and then you can see how it sucks through the other side, getting a lot of solution through cleaning the case. So yeah. I'm not going to spend time on lasers now, although it's part. I see we're running out of time a bit, and it's a total discussion on its own. But it is the new technology. It is the technology that I believe in. Yes, Yolanda?
Thank you, Dr. Heinrich. Can I just ask the last questions? Have you tried?
Can I just finish quick? I'm almost at the end there. So let me
no.
just finish this, and then I think we can go on and
No.
deal with the questions quickly.
Thank you.
Okay, so I know there's a movement in endodontics, and I think that's where we head towards the end of. We will be able to maybe not use sodium or any liquids or any chemicals, and hurrah for that day. But you employ R1 million of technology in endodontics. If you are fortunate enough to have it, I believe in the technology 100%. It's there. But I know it's not there for all, and we still haven't found any other solution than sodium or a combination of solutions that we have to employ in it. But we probably will get to a stage where we could eliminate the risk of a sodium hypochlorite accident. So what do I use? When I start prepping with hand files, I have glide on my file. Because of carbamide peroxide, if I drop sodium onto it, the viscous chelator, you will see how it bubbles out. So it augurs out the debris. So that's where I will start. Then when I start prepping, I would prep with sodium to get, remember we said we want 30 to 60 minutes solution contact onto the tissue. After I've prepped to my final file, I use the following protocol. So when I prep, there's bacteria and there's tissue in the canal. I use sodium to get rid of the tissue in the canal. Then, now I've done with my preparation, I have a smear layer. To get rid of it, I use the eddy with smear off in this case, and I activate it 1 minute per canal. Whether you use a GP cone, whatever you use, or an endovac, you circulate it through. So we have get rid of bacteria, we get rid of the tissue. We create a smear layer, we get rid of the smear layer, but the smear layer block the sodium out of these tubules. So now, once that is gone, I want to go back to sodium to get rid of the bacteria in the tubules. And this is where the endovac plays a vital role by sitting there and circulating a lot of fluids in. 99% of my cases I do in one visit, because after this, there's really nothing more that I can do to keep it clean. By circulating it through, and then I would go and flush a little bit of EDTA through the canals. I don't use alcohol at the end because it dries the canals, and it depends on the type of sealer that you use. Like with bioceramics, you don't want the total dry canal, you want a bit of moist in the canal, for instance. So my last flush is with smear off so that I get a bit of substantivity, and then maybe I will employ a laser if I have it. It's a different protocol if you use a water laser, and that which had the opportunity to work with for 2 weeks, which is great, and something that I wish I had in my practice. And in combination with a diode, it's a different way of thinking a ball game. But with the solutions, this is where I will address it. Activate it, circulate a lot of fluid through, and this is the type of cases, even anteriors, where you can get lateral canals forming. A few cases, just jump through it, and probably let me show you it's a few cases. My last slide, just to conclude, I think endodontics is like golf. Like Gary Player said, the more you practice, the luckier you get. You know, just when you think, now I know it all, it bowls you out. And you get a case that looks spectacular on the x-ray, but it fails. Or you get a case like this, which I saw last week, where there's no pain, we've done everything, and then still there's no area. And if you try and touch this tooth, promise this patient probably will end up losing the tooth or with pain. It doesn't bother the patient. He says, no, it's been there for 20 years. And I saw actually this follow-up this morning, and I was quite amazed. It's a year, just over a year follow-up now. You can see a big area, and it's all to do with irrigation, nothing to do with the file. And a case that I can be proud of, did everything correctly, and I got healing a year after that. But look at the case next to me. I was looking at this morning. I think, I wonder what time that this dentist spent on doing this canal, not get patency, not irrigated. Is a laser, is anything going to do anything more? And for some other reason, it works. And it's all to do with the coronal seal as well. So you can do all that you can, and sometimes lady luck is still not on our side. But for the most, if you want to have success, place rubber dam, irrigate. That's the success of endodontics. I'm sorry, it's quite difficult to speak if you can't see the people in front of you. I hope it makes sort of sense, and I hope you enjoyed it. Thank you for listening. Thanks, Yolanda.
Dr. Heinrich, thank you very much. You are correct. The dental nurses hate endo until you make them part of it. That's the only time they stay awake in the endo, if you make them part of it. And the endo vac is amazing, especially for a dental nurse. She feels part of the procedure. So, Dr. Heinrich, two last questions. What kind of mirrors are you using? The different colored ones?
Okay, the ones that I use, the different color ones, is Zerk HD crystal mirrors. I get them from Inter Africa Dental. But there's also a new one, HD Vision, which I get from David DeBell from Equity Dental. The reason I like it is because they have smaller ones. So it's front surface mirrors. And it really, it's amazing to see how much clearer it looks through the microscope, but be warned that they scratch very easily. And especially with rubber dam, I like the size. I think it's size 2. It's a really small mirror, but works with magnification. It gives me freedom to move at the back. You know, when there's a rubber dam clamp on 7 and you have to work with a mirror. So it's HD Crystal from Zerk, or the ones that I get from David, from Equity Dental.
Thank you. We also now distribute for David, so we also stock those mirrors. And the last question, it's quite a popular question. Have you tried hypochlorous acid as an irrigant and any success?
No, I haven't. No, sorry, I haven't. I can't comment on that. I only use the 6% solution. Also, the reason why I like the 6%, or that's the theory behind it, when me and Professor van der Vyver were doing the lecture or the article, we were fortunate that they were sending us lots of their info and bottles to use. So it's not just the 6% jig. It's not just a jig that is 2 times stronger than normal house jig. It also have surfactants and surface modifiers, which lowers the tension of the fluid so that you can reach deltas and deeper into the tubuli. So it's more than just the solution that's stronger. There's other additives in that as well to use that. So yeah, but on that question, I'm sorry, I'm honest if I say I haven't tried it.
And then the most important question of the evening, do you like my fishes?
Yeah, it's very beautiful. Unfortunately, I can't open the window so that you can see the sea, but yeah, for now, that's better than my view.
Dr. Heinrich, thank you so much for all these practical tips and tricks. It was fantastic. I'm sure everybody learned a lot. Right, Milner?
Thank you for
Yeah, we don't just want to sell the product. We also want to educate the people. And I think you would all agree that the way going forward anyway for the remainder of 2020 will be webinars. So I would encourage you all to sign up for our live hands-on webinars. This year has been a huge challenge, in fact, chaotic. So there's no better time to start looking at products and changing to alternatives that Wright Milners offer. You will notice that there's a lot of changes coming in the industry with regards to manufacturers and suppliers. But I want you to remember that Wright Milners is and has always been very consistent. So there is still questions, Doctor. I do have the names of all. I would
You
love
can
to.
ask questions. I will stay on for a while, so please feel free.
Okay.
And also,
So,
you have my
so
email, and like I say, you can send in. So yeah, we're open for discussion. So please feel
Okay.
free to ask. I will be available for another few minutes.
okay. Of course, there was a lot of congratulations and thank you and excellent presentation and very informative. Do you have
Thank you very much.
Do you have upcoming hands-on courses showing your obturation techniques?
No, nothing planned. But if there's anything people wanted, yeah, we can work on it. So yeah, there's nothing planned. I'm done for the year. I actually told him, I don't want to do any more because it's really daunting sitting and speaking to your computer, and I like to interact with the audience, and we can't do it. So it's new for us all, but this is the new normal. So yeah, but nothing planned at the moment. But yeah.
Okay, can you elaborate on the chlorhexidine you use before bonding your composite?
Okay, so I use the normal 2% on a cotton pledgent. So I will etch, and then I will wipe my cavity clean. The reason I use it is to clean my surface walls. Maybe there's oil, maybe there's debris. And also it inactivates metallo-metal protease, MMPs, which can be detrimental on your bond. So if you read lots of the articles and the new buzzword with dentinal sealing on IES or interdental sealing, that's what you do is you would etch, clean it, and then you seal over it. Because chlorhexidine also gives you substantivity, it creates an antibacterial surface, they say, up until 8 months. And they've done tests, I know, for specific with SDR, where they would take solution, they would etch it, bond it, place SDR on it, throw it in a bottle of water, leave it for a year. The one they use chlorhexidine, the other one not. And then afterwards they would use methylene blue, stain it and cut it. And the ones that they use chlorhexidine on, they would have a better response and a better bond. So there's something in that it creates a stronger bond long term. So that's how I use it. So just a normal plain 2%, not one with added EDTA.
Thank you, Dr. Heinrich. And thank you to all these clinicians that stayed almost 2 hours.
Thank you for staying obliged. Yeah, thank you very much.
All the promotions will be emailed to you. And thank you for all the inquiries about the Endovac. We only have a few left, so we will email it to you. Thank you.
Thank you. Have a nice evening, and thank you for listening. I hope you enjoyed it. Bye-bye. Bye-bye, Yolanda. Thank you.
Thank you.